从事调查的队伍。赖川
Good morning, everyone. We're right at the top of the hour, although I do see some guests joining us. So how about we wait another moment or two and have everyone get settled in before we start. As you're arriving, I just want to note that closed or live transcript is available by clicking on the live transcript bar or button in the menu bar. And this workshop is being recorded. I'll be monitoring the chat throughout the session, so feel free to put your questions or comments in the chat and I'll share them with our speakers. And we'll wait just a moment before we kick things off. I'm seeing a few folks sign on, so we'll welcome them as they come and start in just a moment. See some friendly names pop up. Welcome, everyone. So glad you could be here. Okay, let's go ahead and get started. Welcome to the December Let's See You Well. Today's session is about concussions on campus, featuring our Let's See You Well experts of the month, Doctors Tracy Casault and John Breck, representing the University of Colorado Boulder Medical Services. I'm pleased to welcome a range of participants. Today we have students, staff, faculty, and community members joining us. I'm Erin Cunningham-Ritter, representing the CU Boulder College of Arts and Sciences Be Well program. I'd like to thank you all for joining our Let's See You Well presentation. The Let's See You Well speaker series allows CU wellness researchers and practitioners to interpret the 8 dimensions of wellness from their perspective, thus articulating the value of a liberal arts education through the lens of wellness and overall health, all while supporting a culture of care in the College of Arts and Sciences and beyond. Today, I would like to welcome our featured Let's See You Well experts of the month, Doctors Breck and Casault. And before we begin, I'd like to note that this workshop is being recorded and closed captioning is available by clicking on the live transcription button in your menu bar. Also, I will be monitoring the chat during the presentation, so if you have questions or comments for our speakers, feel free to pop them in and I'll let them know. So now I'm pleased to introduce our experts of the month. Dr. Tracy Casault, after finishing her undergraduate at medical school and medical school training at Michigan State University, Dr. Casault moved to Colorado to complete a residency in family medicine. Following this, she completed a sports medicine fellowship working with the University of Notre Dame. Prior to coming to the University of Colorado, Dr. Casault spent time working in emergency care centers in rural Colorado, including several seasons working at ski-based emergency centers in Breckenridge and Winter Park. Dr. Casault is a physician with the CU Boulder Medical Clinic. Welcome, Dr. Casault. And Dr. Breck grew up in Michigan and went to undergrad and medical school at Michigan State. By the way, we have a cat over here named Tom Izzo, just in case.
There you go.
Yes. He then completed his residency in family medicine at the University of Michigan. After residency, Dr. Breck received additional training in sports medicine at the University of Florida, and he serves as the lead physician in the CU Boulder Medical Clinic. I'm pleased to welcome you both. Let's give a quick round of applause for our awesome Let's You Well presenters of the month and kick them off. Woohoo! All right, I'll do a stop share and turn it over to you.
All right, good morning, everyone. Thank you for joining us. I'm going to share my screens. We have some slides to run through. Really honored to be here. Appreciate you guys inviting us and for all the great folks listening in. Please ask questions, use the raise the hand feature, use the chat, or even just yell out. We're happy to take questions throughout the presentation. This presentation we've given a couple times, sometimes based toward providers, and then sometimes also just directed at public folks. So there's a little bit of clinical information, and there's also just kind of some general knowledge stuff, and then hopefully a lot of kind of slides that pique your interest, and we can talk more about the kind of complications and kind of the tricks for concussion management that we see here on campus. We just had a nice intro. Thank you, Aaron. Tracy and I don't have any disclosures. So the plan today is to define concussion, which turns out is trickier than it should be. We'll discuss the frequency of concussions in the college health population. Excuse me, guys. And especially those that are not related to sports. I think we hear a lot about sports-related concussion, but we don't talk a whole lot about non-sports-related concussions. We'll discuss again that concussion remains a clinical diagnosis. We'll review some classic warning signs or red flag signs, and then also review the kind of resources we have available to students. So if you interact with someone with concussion questions or concerns, a good way to get a hold of us or other folks on campus who do this work. Oh, excuse me. So definition. So our first definition is pretty short and sweet. This is the definition that comes from the American Medical Society for Sports Medicine, which is kind of Tracy and my, governing body kind of. They're kind of who we work through for our sports medicine fellowships. So a concussion is defined as a traumatically induced transient disturbance of brain function that involves complex pathophysiology. So there's some good stuff there. I think we'll talk a little bit more with another definition, but there's some key features here that we want to watch for. This is another definition. This comes out of the consensus statement or consensus group that meets every 5 years. The first one some of you may have heard of is the Zurich consensus statement. This is one of the first times concussion researchers and providers got together and tried to define a concussion. In Berlin, they came up with a new definition, which I think is quite good. And then they just met again in Amsterdam a couple weeks ago. We haven't heard what's coming out of that meeting yet. But I think the key features here I've underlined are concussion is either caused by a direct blow to the head, face, neck, or elsewhere on the body, which I think is a key feature, right? So if you get hit or fall skiing and maybe you don't actually hit your head on the ground or on another person, but you kind of violently move your head around, the brain is moving within that skull. We'll talk a little bit about that, and that can cause injury. But I think that's important to remember that you don't have to be hit in the head to have a concussion. But you do need to have an impact, right? So there has to be some sort of force associated with the brain. So again, versus a headache or, a migraine can have dizziness and some of the main features we look for in concussion, but there isn't that history of an injury. Usually involves a short-lived impairment of neurologic function that resolves spontaneously. Again, this is, oops, darn it, my slides are a little bit timed weird. This is super important because this should resolve, right? So concussion by definition resolves. And if symptoms are not resolving, then we need to look for other diagnosis. Skip down a little bit, largely reflects a functional disturbance rather than a structural injury. And this is key when we're talking about imaging of the brain. Imaging of the brain outside of the newest, fanciest MRI should be normal. There shouldn't be any structural damage noted on the brain. If there's structural damage, you're kind of leaving the concussion category and moving into the kind of traumatic brain injury or more significant brain injury part. And this last part, thinking about has a range of clinical signs and symptoms, and it may or may not involve a loss of consciousness. Previously, many years ago, that was part of the definition is you had to have a loss of consciousness, and we know that is not true anymore. So now let's talk about what's happening in this injury. So again, this is obviously a very over dramatized picture, but the idea here is the head moves, the brain moves inside the skull and is injured. Now, most of the time we don't have this actual contacting of the skull, but that's the idea, that there's motion there. And then what happens is the neurons get irritated, right? So there's this big change or kind of a motion at that neuron level, causing some physical damage, which then causes some changes in the cell membrane, which leads to a pretty significant ionic flux, or calcium entering and leaving the cell, potassium entering and leaving the cell. And then that changes the cell's homeostasis, right? So that cell can no longer function appropriately. The slide or the graphic on the right is kind of looking at those, different ions and things like that as a percent of normal. So as you leave that dashed line, you're leaving the normal. So you can see that the ions change significantly. Glucose changed significantly. Glucose is blood sugar, and blood flow changes significantly. And then the key, I think, again, we're seeing this general trend back to normal, back to that normal at about 7 to 10 days. And that is clinically, in our experience, when we see recovery for 90+% of our students, is they have an improvement in their symptoms about this same time, which I think correlates really, really well with kind of what this graph is showing. So again, we think about blood flow and we think about glucose a lot in terms of treatment. We'll talk about that later. There's not a whole lot we can do about ion changes, but we can do a lot about, making sure the brain is getting adequate blood flow, and making sure the brain is getting adequate glucose. So that's a lot, but we'll keep rolling through. So how frequently does this happen, right? So I think the key here is that it happens frequently, right? So these are some national data and international data from the WHO, and they're looking at kind of estimates of mild traumatic brain injury. That's what mild MTBI is, and concussion is one part of that mild traumatic brain injury kind of world. And so we're seeing significant numbers here, and I think the numbers peak between 9 and 22. They've seen this significant increase in presentations to the ER of young adults between 2001 and 2002 to kind of 2009, 2010. And I'm sure we'd still see that same increase, once this newest data comes out. So very common, especially in this age group, and we're seeing it more and more and more. The question Tracy and I always talk about, and I think concussion folks around the world talk about, is how much of this increase is recognition, meaning we're more aware of this injury, we know what it looks like, we're talking about it at Pop Warner football coach training, and maybe we weren't doing that previously. And so how much of this increase is due to actual changes in the frequency of injury, and how much of this is due to people accessing care and getting diagnosed, right? I think this last one's a great number here. Approximately 19.5% of adolescents report having been diagnosed with at least one concussion in their lifetime. And that's pretty consistent with what we see. If not, we see a little bit more in our clinic. So this is numbers from our clinic. So Dr. Casault started our concussion program back in 2014, and we started collecting data in 2015. And so with some help with some researchers around campus, we were able to put together this slide, this study. And so we looked at concussions in our clinic between 2015 and 2018. To make the study more generalizable, we kind of limited it to undergrads and during the academic year. We probably saw a total of about 1,350 concussions total throughout this time, but with the limitations, we saw about 1,100. The key, I think some interesting things here are this biologic sex part. So I think many times when we think about concussion and we think about kind of the movies we've seen and the news reports we've seen, we think about this being a young male sports dominated injury. And at least in our campus, that's absolutely not true. This is a 100% of 50-50 injury. Young women are just as likely to get a concussion on campus as young men. We also see that falls represent at least as many cause of concussion as sports do, right? So, especially when you add up falls plus, hits to the head, meaning, a big book fell off their highest shelf and hit them in the head, or, they're hit by a snowball, or who knows, motor vehicle accidents, all these kind of other non-sports related injuries. We actually found that in terms of CU undergraduate students, sports are not the most common cause by quite a bit, excuse me. And then the last thing here is that our prior concussion history, I think, is interesting. When the folks who come to Wardenberg to be looked at for concussion or be diagnosed with concussion, almost 46% of them have had a previous concussion, okay? And almost 5% have had 4 or more, right? So a pretty significant previous concussion burden. And again, it's still unclear how much that is important in terms of their diagnosis or in terms of long-term health, but it sure makes them more aware of concussions and more concussion symptoms. This is interesting. This is when people get concussions on campus. So I think this is interesting in terms of the total incidence, looking at that bottom line there, 2.7 per 1,000 in August versus 1.1 in December and May. And so, we don't have any great data to prove why this happens, but I think we can all make kind of generalized ideas of what's the academic load like in August versus December, and what's the behavior of students like in August versus December. What's the kind of risk-taking, threshold for them. And then also, when are they on campus, right? So they come to campus mid-August and they leave in December and May. So I think, again, with those little caveats there, it's something to think about. Next thing is kind of where we're at now, right? So the pandemic obviously threw us for a pretty big loop in our concussion-based clinic also, right? For a number of reasons. One, we just had less patients in town and on campus. We also had a lot less activities, right? Less skiing, less mountain biking, less commuting, less bike riding, less going out to parties, all that stuff. So our concussion numbers really came down, obviously, and now we're seeing them start to pick back up. So pretty significant growth there for a while. And then now we're kind of starting to pick back up again.
Okay, I'll take over here. So we're going to talk a little bit about the clinical picture, some of the signs and symptoms of concussion, and whether you're in the classroom as a student, as a professor, as an advisor, kind of monitoring these students, depending on how you see them. A lot of times this is an invisible injury, right? And so that's the most important part is we tell our students and try to give some documentation around this, because some people have not believed a student that this is an injury. But there can be sort of these 4 categories of symptoms, signs and symptoms, whether it be physical, and we'll go through the details of that. So about 70% of the time with a concussion, patients are going to have headaches. Now, that's not 100%. Okay, that's not 100%, but a lot of times that fits with, again, like John said, that hit to the body, that hit to the head. And so we know there is some trauma prior to the onset of these symptoms. Because if you look at the details of these physical, cognitive, symptoms, these could be a lot of other things, migraines, illness, you name it, mental health issues. And so we have to sort of tease out that there was truly a mechanism of impact prior to the onset of symptoms. And we monitor these symptoms over time with a grading scale, which we'll get to in a little bit. But a lot of the big complaints that we see initially, especially in that first week or two, is going to be headache, nausea, visual changes, sensitivity to light and sound. So, you're going to see students in the classroom wearing sunglasses, maybe having earplugs in, wearing a hat to sort of tune out those overhead lights that are really disturbing and uncomfortable at first. And then how they're going to feel cognitively is quite slowed down. Recent recall or kind of new learning is going to be a little bit difficult for them. They're going to be more forgetful. They may have some word finding issues. We can move on. And then emotionally, and we'll talk about this too in a moment, but when those things exist at baseline, we'll see a ramping up of those. Now, that being said, we can have patients who have not had any kind of emotional disturbance in the past, who all of a sudden are tearful at the drop of a hat for no reason. And they feel like, what's wrong with me? They just don't know how to explain what's going on with them. They can be very tearful or snapping at, people in their lives, their roommate, and that's not their normal baseline. And then with sleep, it can really come across all categories. They can either have trouble falling asleep, trouble staying asleep, sleeping more than usual, sleeping less than usual. Overall, they're pretty much drowsy and fatigued more than their baseline.
Yeah, I think it's important to remember these two, because I think we all are pretty comfortable thinking about these as classic concussion symptoms, the physical and the cognitive. I think sometimes we forget or maybe have not seen the emotional or the sleep disturbance side of concussions, and that can be sometimes the most visible symptom for some folks. I think we all are kind of comfortable with the idea of sleeping more when you are concussed, but it's definitely not uncommon to have trouble sleeping with concussion.
Right, and as you think about it, who hasn't slept for a few nights in a row and they're feeling more emotional instability, maybe some more symptomatic signs like headaches, nausea, just not feeling well, and couple that with the recent impact, they're just not going to be doing very well. So a lot of the danger signs, and this is what we look for, especially on presentation or where we might want to send somebody to the ER initially, is one pupil larger than the other. So we're looking for pupillary reaction when they're describing double vision, if they're having a deteriorating conscious state. So that's usually pretty quickly. They may have a hit and then kind of be sort of deteriorating and not really speaking clearly, have garbled speech, be difficult to rouse. Those are people that we want to get to the ER immediately. Headache. A headache is one thing, but worsening over time. Again, speech difficulties, numbness in their extremities, vomiting. Certainly some patients can vomit maybe once or twice the first day, but repeatedly vomiting, multiple days of vomiting, they need to get a brain scan and make sure there's not a small brain bleed going on. Loss of consciousness, we do take that seriously. And like John said, some of the previous guidelines, if you had a loss of consciousness, it was graded as a higher concussion number. But now we don't have that grading scale anymore because some of the evidence has shown that if there is a loss of consciousness, patients actually recover more quickly. So it's not so much of you have a grade 1, 2, or 3 concussion anymore, but that you either do or you don't have a concussion. And that's kind of what we're trying to decide. So again, the American Medical Society for Sports Medicine and the position statements continue to come out saying that concussion is really a clinical diagnosis. So we really have to look at that history, the injury itself, and then look at the physical exam findings to see what's going on, to see if this is truly a concussive event. Unfortunately, we don't have anything at the clinical level to draw blood. And I tell my patients this all the time. We can't just draw your blood and say you have a concussion, but we kind of deduce this based on what you presented with. And then again, this history. So how did it happen? When did it happen? Was there a loss of consciousness? If so, did somebody witness it? How long was it? Because sometimes that loss of consciousness, greater or less than 30 minutes, we're going to be maybe making different decisions. And then we take a lot of time to really look at their previous concussion history. So how many have they had? When have they occurred? How did they occur? Was it, on the sports field? Was it slip and falls on ice? How did they happen? And then what we really look at over time is how these concussions, how the recoveries are going for these concussions over time. So the first concussion, maybe you had a 2-week recovery. The second concussion, maybe it was a 3 to 6 month recovery. The third concussion, it was a 1 year. These are patients that we're going to have a totally different approach to than a patient who's had 2 or 3 concussions, all with a 1 or 2 week recovery. So looking at these longer and longer recoveries with potentially less and less impact is something that sort of piques our clinical judgment here. And then we'll talk more about this in a moment too, but the risk factors for prolonged recoveries. We also get into the details with them at that first visit with what is their major? How many credits are they taking? Who have they spoken with in terms of their professors? Have they tried to communicate with their professors yet? Because what we have found, especially in the last few years, and I can only speak to this, but John can see if that's the same, but it went from when we first started this back in 2015, 14, 15, 16, where there was not a lot of support per se around this, to professors being very supportive around this in the last few years, which is great. So I think that awareness of injury, despite being visible, is now out there.
So I think Tracy's great. That was a great, explanation of this is a diagnosis we make using as many tools and as much information as we can gather. one of the things we look at is symptoms, right? So we're looking at, what do you have and how significant are those symptoms currently, right? So we're looking at something called post-concussion symptom scale, and it's a series of 20 plus questions looking at different symptoms, and the student grades them from 0 to 6. Again, the problem is these symptoms are stuff that many of us have felt, even if you've never had a head injury, right? If you don't sleep for 2 days because your baby's awake or whatever, you feel like you're in a fog and you're slowed down and you feel a little bit off and you're fatigued, right? So these are symptoms that are pretty broad, which I think is there's a theme here in concussion diagnosis and concussion kind of evaluation, is that many of the symptoms we look for overlap with other injuries and with other, medical issues. So something to watch for. This particular scale is interesting because when you look at these symptoms, this is a great study kind of examining what I just talked about. What they did was they gave these same symptom questionnaires to folks with an orthopedic injury and folks with a mild traumatic brain injury, and they had them fill out these questions. And it turns out that in terms of their, what they chose, only 6 things were different between the two injuries, right? One was, we're talking about ankle injuries, and one we're talking about mild traumatic brain injuries. But in almost all the categories, they both picked significant, symptoms, right? So the only ones that were different in terms of concussion were short-term memory, partial loss of consciousness, and reading issues, right? So all of the other ones, including headache, including concentration, including irritability, including feeling dazed, were positive in both injuries. So again, we have to use this inside the story of what we're looking at. The same thing again, where we just handed that questionnaire out to university students, and it's not us, but another group did this. They handed out these questionnaires to folks just walking across campus. And it turns out that almost 76% of those students circled at least some fatigue, taking longer to think, poor concentration, sleep disturbance, frustration. So again, a lot of these symptoms are symptoms people have at baseline, right? Or on their, if you catch them at 9 in the morning. So again, we always have to put these symptoms in, inside the picture. Now, those two studies sound like that we shouldn't even be doing it, right? That seems like there's not a helpful tool, but it turns out there is still some validation here when you look at, these scores compared to the highest, newest, fanciest functional MRI, which again, we're not using in clinical medicine yet. So they do correlate there. So they are still useful, and it is a useful tool, especially for monitoring improvement. We have folks fill that out every time they arrive. Every time they go to PT, they're filling it out. So it's kind of a nice way to watch their symptoms change. And if we see it significantly worsen, that's a good kind of heads up to Dr. Casault or myself to kind of like, hey, let's check it. What's going on? How come it's suddenly changed? So it's a nice tool, but again, like any of this stuff, it needs to be used in context.
And so this goes a little bit into what I alluded to a little bit before, was the risk factors for a prolonged or protracted recovery. So there's evidence that any of these baseline diagnoses or symptoms can potentially, and not always, but potentially put that person at risk of a prolonged recovery. So something from 7 to 10 days to several weeks or longer. And so this is another thing we screen for, and the student fills out on the grading on a check-in questionnaire, is if they've had a prior history of concussions and how many, motion sickness, eye issues. So we really screen for that because, as John alluded to, there is some eye issues that can be diagnostic when we see a patient for a concussion. Migraines or history of headache disorders, even in the family. Some of these mental health concerns, anxiety, depression, ADHD, learning disabilities, sleep issues, and any history of abuse or trauma. So that's going to kind of take their symptoms and potentially really crank up the volume on them. And so we see that a lot with students who have some of this baseline, but when we see them for that first visit, we've gotten all this history. So now we have a heads up for that particular student that this is what we've got to watch for on our weekly basis when we see them and check back in.
Yeah, I think it also provides a lot of reassurance to folks that I talk about, and we talk about concussion being an amplifier, right? It kind of takes whatever you have at baseline before you hit your head and kind of cranks up the volume on that. So, you know, it just gives people reassurance that, you know, why am I suddenly much more tearful, or why am I having nightmares again about previous trauma, or why am I suddenly, you know, my ADHD medication isn't working as well, right? It gives a lot of kind of reassurance that yes, we know and expect that your prior kind of issues may be worsened during this head injury, and that they will return to their baseline. So that's something we can give people reassurance about. But also that these are the folks we watch closer, right? These are the folks we kind of get more aggressive with, and we'll talk more about treatment in a couple of minutes, but these are the folks we kind of get into treatment sooner. So this is the idea here. We're looking at, you know, folks who present to Wardenberg for concussion, and then we looked at who, before they even presented, who carried this diagnosis of anxiety, ADHD, depression, and insomnia. And so what we did was we compared those rates to any other visits to the clinic. And we found that folks presenting for concussion evaluation carried these, you know, different conditions at a higher rate than anyone else that comes to our clinic. So that goes along with this idea that people with previous anxiety, ADHD, depression, insomnia, or any combination of above are going to struggle a little bit more with their concussion than folks that don't carry these diagnoses. And that's the theory here, is that the reason this rate is so much higher is because folks with these need more help, and they're going to come and seek out more help because they're struggling more. You know, this goes along with the idea that we're probably not seeing every concussion, right? We're only seeing the folks that are really struggling, right? So many folks who have a concussion, especially mild concussions, and are healthy, and the majority of our students are, you know, recover very quickly, and many don't present for care. And so the folks that are struggling seem to present more. So that's kind of where we're at with history. We're kind of talking about all that stuff. We're looking for these features of prolonged recovery. We're kind of giving recommendations on kind of, hey, here's what to watch for. And then we do some physical exam. And I think the thing to remember about physical exam is the majority of this physical exam is really looking to rule out emergencies. We're really looking to try to figure out, is there a neck fracture, or is there an injury or possible small skull fracture, or is there something else going on that makes this a much bigger deal that needs to be evaluated with scans and things like that. So a lot of our physical exam is really looking for these kind of emergencies. And I don't know if any of you guys have read these tables before, but this is common in medicine. We're looking here at a recommendations or grade of evidence to support or not support the use of different physical exam techniques to make the diagnosis of concussion. So obviously, I don't want you guys to go through all these and know all these, but the idea here is that A is better than B and B is better than C. And so you can see a lot of B's and C's in terms of all the tests that we do in a normal evaluation for concussion, because majority of these tests are not looking to diagnose concussion, right? They're looking to kind of rule out other things. The ones I would say are, and what they found to be kind of grade A evidence, are looking at some of these eye screening. So we can look at that. And then also looking at pre-injury psychiatric difficulties. That's kind of what Dr. Casault was talking about. These kind of pre-existing conditions are really important to know. So I think, you know, this is interesting just as a reminder that what we're really looking for a lot of times when we're doing this big, long physical exam is to rule out other issues. These are kind of, again, this is more for the clinical folks, but, you know, we're looking at reflexes and you know, how oriented they are and things like that. So we're kind of quickly moving through this. The other nice thing is a lot of times with this exam, you're able to kind of chat with the patient during it and watch how well they're able to follow directions and how quickly they can kind of recognize what I'm asking them to do and then go through it. So I think this is a really nice way to do it. Here's some of those danger signs we're looking for. Again, these are the kind of scary things that, you know, you see once or twice in your career outside of the ER and you send them right over. But all of these are concerns for skull fracture or for, you know, injury that's more significant than a kind of standard concussion. The one on the far right here is actually someone's eardrum. That dark black fluid is blood. So the concern there is that there's been a fracture behind the middle ear and it's now kind of behind the eardrum. I've seen this once and the patient looked absolutely fine. And we sent him over to the ear, obviously, and he did have a small skull fracture, but he was very shocked. We were both very shocked see that because he was doing so well. So again, that's the other thing is these young people are pretty amazing in what they can tolerate. But these are the things we look for. Again, looking for more tools we use within our kind of repertoire to help diagnose this. I get a lot of questions about computer-based testing. People, at least at this point, many have been exposed to computer-based testing like IMPACT. You might have heard of that. That's a kind of computer-based test looking for concussion. What these tests are trying to replicate more formal neuropsychiatric testing. So looking at cognitive, reading comprehension, reaction time, and in a shorter, more kind of mobile and easy to give test. The problem with that on our campus is a couple. So one is we never use them in isolation. And anytime someone's telling you that your impact score has changed and therefore you have a concussion, is not really understanding what impact score is, right? Because again, a bad night's sleep can impact your impact score, your computer-based score. So you need to understand kind of what are the, what that test is asking for. And its limitations. So you got to be careful with that. And then probably most importantly on our campus, we don't have baseline tests for all of our folks pre-concussion. And that's, I think, where this test can be useful and where they use it at the kind of higher NFL and NCAA varsity athletes stuff is they can baseline these athletes prior to ever entering the field and know kind of what their score is, and then they can watch for changes throughout the season. That has its own set of difficulties, right? So lots of data out there about people not taking the test appropriately or not being truthful with their answers. So again, computer-based testing definitely should never be used alone. Should never be used as the only thing to help make your diagnosis, and definitely shouldn't be the only thing you use to decide when someone's better. But it is a helpful tool in the right circumstance. This is something we hear a lot about, or questions about is, are there any blood tests? And we talk about this a lot in terms of wishing there was, and is there any sort of advanced imaging out there? Again, the big sign for these is they're not ready for prime time. They're not available in primary care. You're not gonna be able to get it in any sort of time that's useful in terms of what you're gonna recommend to the patient. And so oftentimes we're asking ourselves, well, what would it change in our course? And for the majority of folks, it wouldn't change anything, right? We're going to recommend the same things until we'd be able to get that, but either way, we're not having it yet. Just for you guys, if you're out there and you're thinking about this is kind of where these things are looking, right? So there's these really high resolution functional MRIs looking for microhemorrhages in the gray matter. Kind of at that gray-white junction. They're looking at, energy expenditure, which we've had some folks look at on our campus, looking at kind of glucose use in certain parts of the brain before, during, and after, injury. And then again, looking at these other kind of, again, highly specialized MRIs. I think what we're all hoping for eventually will be a blood marker or a biomarker where we can have someone get their blood drawn and tell them, yes, you have a concussion, or no, you don't have a concussion. So one exciting one for a couple of years there was something called S100B, and they were using that even in the ERs and in some Scandinavian hospitals, looking at who needs a CT scan and who doesn't. So there was kind of a cutoff there, and if you hit some sort of level, if it was higher than this, they said, yeah, there's a good chance you have a brain bleed. Sorry. And so let's get you in the CT scanner. But again, not super helpful for our folks the majority of the time. And then this last study is relatively new, and actually some of the folks from University of Colorado involved with this. So this is through the NCAA and Department of Defense CARE Consortium. And this is a kind of a national research project looking at concussion. And one arm of that is looking for one of these blood markers. And so a couple that they're researching are these kind of long named, blood enzymes that they've found or changes in the blood. So again, it's kind of like what we're all hoping for. We're not there yet.
Okay, so we're going to talk a little bit about treatment. We really feel that the concussion is treatable. So we look at those symptoms, we monitor them at every visit, and do these serial grading scales, like we presented with scale 0 to 6. and sort of see where these symptoms are at this point. We really also reiterate to students, our patients, that the majority of them are going to recover quickly. So like John said earlier, 90% of them are going to recover in about 7 to 10 days. A small percentage kind of persisted beyond that. We do have, I certainly tell students though, when there's a huge cognitive load, for instance, right now, this week, finals, it's probably not going to be 10 days because despite everything else, there's such a large cognitive load that those symptoms are probably going to remain. How you've been treated for concussion in the past matters, how your family views concussion. I have a lot of patients coming in saying, well, my mom told me I had to wake up every couple hours, I had to go lay in a dark room. And those are old news things, and we'll talk about that here in a moment. But the other thing to be aware of is the good old days bias.
Mm-hmm. Yeah, so what this is this is in the folks who have more persistent symptoms. So, when you've had kind of concussion-based symptoms for a while, and then you think back, and what they saw in these studies was that folks would, when they did their scales or when they asked questions about pre-concussion, pre-head injury status, they would say they'd never had a headache, or they'd never felt drowsy, or they'd never felt fatigued, right? Because when you're looking back at that pre-injury time, it's one of that like, oh, so much better before this ever happened. But it turns out probably that's a little bit biased by the patient. So again, it's all part of the same story of kind of saying, you know what, vast majority of people are going to get better. You're going to get better quickly. Your vast majority are not going to have any long-term sequela. And so I think giving people that confidence and that reassurance, and their families that reassurance, that alone can help treatment quite a bit.
And we really look at individualizing this treatment. And we reassess them usually weekly until they're better. And then we have a large team-based approach that we'll talk about here momentarily. The big message too is that absolute rest is wrong. So there was a study a couple of years ago that showed, it was out of the ER, but they took patients and half the group laid in a dark room for 5 days and the other half were allowed to go about their day-to-day life. And those who went about their day-to-day life actually had much lower grading scale scores than those who went and laid in a dark room. And we like to say, remember the last time you were sick and laid in bed for a few days. Everything was sort of groggy, you just felt sore, your brain's not functioning as well. And so just a good reminder that early light activity, going about your activities of daily living, is okay to do from the beginning.
Yeah, and they've had this is multiple studies now that this kind of absolute rest is not key. Now, one caveat is recently there's a new study looking at screen time in young people, right? So this is a pediatric group, but our group is touching that pediatric. And there was some improvement with 48 hours of no screen time, right? So folks that abstain from screens for the first 48 hours did do slightly better. But again, it's not significant. But I think the key is, and we've seen this clinically, is the folks who show up to us a week after they've hit their head and they tell us that, oh, what have you been doing? Or tell me about your week. Like, well, I've just been laying in my bed. Those folks are doing very poorly. They have a lot of symptoms. They don't know when to eat. They don't know when to wake up. They don't know when to sleep. And the folks who have tried to push, while sometimes they don't feel perfect, overall, they're doing a little bit better. We also talk a lot about, both Tracy and I, with our patients, that there's no evidence that studying while concussed will cause further brain injury, right? So it might make you feel not great. It might kind of wear you out, but it's probably not causing further brain injury. And so again, we want to talk about doing this the right way. And that brings us to this slide in terms of using our reserves in the right way. But again, we're probably not causing further injury. We're probably just not allowing people to be comfortable and to have as much energy left over for recovery.
Yeah, and this slide gives you a good idea of how we try to explain this to our patients. Before they maybe had 50% reserve, and they could, equally spend their energy cognitively, emotionally, physically. They're going to the gym, they're hanging out with friends, and they're going to school. But now, since the injury, their reserve is a lot less. And so, maybe half of their energy is spent cognitively. And that might look differently than before because they're able to study for 20 or 30 minutes before they need to take a visual break for 5 or 10. So all of a sudden that cognitive time and energy is now taking up half of their time. Their emotional symptoms are up and down. there's because of, many other factors, they're not able to get out and do things with their friends as much. So they're feeling sort of, out of the mix of what's going on in life. They're just, because of the concussion itself, feeling emotional ups and downs. And then physically, that physical burden of symptoms. So the headaches, the nausea, the light sensitivity, all that is taking up so much of their physical kind of energy expenditure that reserve is really less.
Yeah. So I think, again, that's a good reminder. And we talk to patients a lot about this, is like, again, doing a little bit of homework, doing a little bit of reading, going out and having coffee with a friend, going on a light walk. That's kind of how we start treatment. And that's pretty much what this is that we'll talk about that in a second, but like we want to use this energy model to explain doing some is good, doing a lot, especially in the first little bit, probably is going to be overwhelming and give you symptoms. And then again, slowly over the next 10 days, we're going to see this shift back to your prior energy allocation. Check the chat real quick. Someone asks, for someone who's had 4+ concussions, what are the long-term implications, PCS, and what plan of action would you recommend?
And PCS is post-concussion syndrome.
Yeah, so this is hard, right? This is kind of where a lot of research is right now happening. It's kind of trying to figure out, why do some folks have so much trouble with multiple concussions and why do some have none, right? So I think the classic example everybody knows about is kind of NFL players looking at, brain injury. And so, how come some of our NFL players have horrendous and horrific brain injury with protein buildup in their brains and progressive, almost like dementia symptoms and things like that. And while some of them don't, right? And so that's the problem we're at right now, is it's unclear why some folks with head injuries have some, one outcome and folks with a different head injury have other outcomes. And so it's really hard to say in terms of, is there a hard number that we say like, you've had 6 concussions, now you shouldn't ever go mountain biking, or you shouldn't ever go skiing, or you shouldn't play soccer anymore. There, so far, at least, we haven't had that, because everyone's brain is different. Everyone recovers from these differently. And again, we're not sure what that is that changes. Some folks get this terrible outcome and some folks not to. And so what a lot of times Tracy and I talk about, and what we look for in our patients, is more of, what did your recovery look like post that 4th concussion, right? So if the first concussion, it took you, 4 days to feel better and you're feeling great and you're right back to school next week, versus the 4th concussion, you had symptoms for 2 or 3 months and you had a lot of trouble and you needed a lot of, physical therapy or cognitive help or things like that. That's one sign we look for, is kind of, if with the same amount of head injury, is the recovery getting longer and longer and longer? That's one of the things we watch for in terms of maybe we should be a little more careful in our activities. The other thing we watch for is folks that have symptoms with smaller and smaller head injuries, right? So maybe you had a big classic football injury in high school, and then a couple years later, you have another one. And the 4th one, it turns out you were just standing up and you hit your head on your bunk bed, right, in your dorm. And now that's taking you 2 months to recover from. That's one of those warning signs where you say like, okay, how come this person's brain is not tolerating mild insult, right? While some folks would never get anything from that, they'd be like, ouch, that my head hurts, but not have any symptoms. Some folks do. And so why is that? So that's kind of what we look for the most. And then making sure people have fully recovered from their previous ones, right? So sometimes there's some lingering, we talked about the eye motion stuff, the dizziness or the balance stuff. Sometimes those very subtle physical findings haven't fully recovered, or some folks never recover fully. And so or until they work on them. So we often recommend people get in to do a little bit of rehab on those areas. And we've seen good improvement, even when people who have not, had their head injury 2 years ago, and they're like, man, I just, whatever, I'm always dizzy, or, I get this sensation, or it's hard to read, or screens are tough. And you can actually help a lot of people with that kind of stuff. So I think, sadly, there's no hard answer in terms of this is the number where you should be super, super careful. We're sports medicine doctors. We believe strongly in physical activity and being outside and being active. So the last thing we want to tell people is to retire from something they love. But that discussion does happen But we don't often use the hard number to do that concussion. Make that decision. We talk about more of that symptom stuff, and that's never made alone, right? That's made with neurology. That's made with MRIs. That's worked with a lot of experts before we really talk about retiring someone from something.
Yeah, and so let's see what that next slide shows, because I want to make sure we talk about okay, so real briefly, I'll talk about this effects on the classroom. How is this going to look to, to the student, to the professor? So again, like I mentioned before, the students comes in wearing sunglasses because of light sensitivity, wearing hat. We try to have them, go back to class, and we write them for, may leave class if symptoms worsen. But looking from the projector back down to their notes and up and down or side to side, from reading boards across the room, some of those eye symptoms can really flare up and cause that student to struggle to be in the classroom. So really kind of taking things slow, short bursts of brain activity, studying cognitively, and then taking those short breaks. Return to physical activity. So evidence supports early light activity can help improve recovery, right? So we want you to walk 20 to 30 minutes a day from the get-go, as soon as you can. Get that blood flow going through your body, through your brain, flush out some of those biomarkers, chemicals that are kind of shifting in that brain. Light body weight exercise. And then we talk with them very clearly about what does a return to play or, return to exercise look like for you in particular. But we kind of work through that with each student, but we're still not clearing them for any kind of high risk sports.
Right. So that's the key thing. Is like, yes, walking, yes, even light exercise is fine. Do I want you back on the ski slopes? Absolutely not. Right. And so that's going to be a discussion you have. And again, this is different for everybody, right? So one person might feel pretty darn good at day 6, and we're talking about, hey, what does easy skiing look like, versus other folks who might be quite a bit of time. Here's another chat thing. For those,
kind of rehab?
Yeah. So looking at rehab, so there's a lot of great new rehab coming out of the through physical therapy, and that's a group we work with a lot. So again, part of our concussion team is a physical therapy, and that's probably actually our #1 referral by far, because a lot of those kind of mild eye tracking symptoms or that mild dizziness, we can improve quite quickly. And this is becoming more and more common. So if you're not a student and you're not eligible to come and be seen at Wardenberg, that's okay. Concussion rehab, especially kind of what we call vestibular ocular motor rehab, to the eye balance, inner ear kind of balance reset, or that system is becoming more and more common. So that's definitely available in the community. And so if that's something people are still experiencing or never felt like they got all the way better following a head injury, I think I would highly recommend you go and chat with a physical therapist and ask them if they're comfortable treating concussion. And that could probably be a great place for you to start. I really would recommend that. It's a great, the amount of change and the improvement people get from that is really awesome.
But have kind of a primary care sports medicine doctor. Sure. That is your primary driver, kind of case manager, if you will. And that's sort of what we are, right? So we know about all our on and off campus resources. We have developed a team around campus. We meet, annually, maybe biannually, to kind of meet and talk about what's going on fronts from student support and case management, disability services, CAPS, speech and cognitive therapy through the Speech and Language and Hearing Science Center, and then our physical therapy team on campus. Also Office of Victim Assistance, because some of these are happening, traumatically or partner violence. So this is kind of clinically where we come and talk to that patient and see what their history is, and then get them plugged into the appropriate, treatment or resources for that particular student.
Yeah. And our job, again, we are able to see them frequently and kind of have the whole picture. So we get the PT notes, we get the speech notes, we get the notes from their therapist. We can kind of put the picture together and say, okay, I think we're still having issues here or here, and we can kind of get them where they need to be.
And then if we need higher level care, they have a nasal fracture, they have facial fractures, they have, a complicated migraine history or post-concussive symptoms that are lasting greater than 6 months, but many reasons why we're going to get specialists off campus involved, and sometimes early on.
100%. Amazingly, we're out of time. I can't believe it. So how do you get a hold of us? You can email us, you can Teams us. If you have a student that's interested in receiving care or has questions, they can call our main line to schedule an appointment with either of us. And the same with, they can do that through the portal. I'm going to pop off the screen and see if we have more questions or if people want to ask questions. We have a couple minutes to go over them. All right, that was really fast.
There might have been, let me look at the chat. There's possibly something in here. Oh no, okay, I think we had all the chat questions. Oh, Erin, I think you're on mute.
Erin, you're muted.
Thank you. Just a quick question. Could you tell us a little bit more about how you might coordinate with disability services? So our classroom leaders or our academic advisors or academic coaches may be aware of kind of that process.
Yeah, so we do recommend they work with disability services, and then what we can give the student through disability services is a clinical documentation of kind of our suggestions and their diagnosis and when they're injured. The problem is sometimes folks have a little bit of trouble getting into disability services, and they've gotten so much better in the last couple of years. They really have done a great job, but it used to be a little bit of a delay. And so sometimes we would have them getting better by the time they made it into disability services, and they're already a week behind, right? So again, we try to get folks to really talk to their professors as soon as possible, right? So I often say, even the first time I meet them, that say, hey, I know this feels like it's getting better, and I know it's probably going to hopefully won't be a big deal, but I still recommend you contact your professors and maybe your academic advisor and just let them know, like, hey, I've been diagnosed with concussion. I'm hopeful it won't be a big deal, but I just want to let you know. And then if things kind of continue, we can kind of get more formal in terms of recommendations and kind of talking about what that means academically, where you're at.
That's right. And we give them a very specific summary report of their visit that we print off, ask them to take a picture of it on their phone in case they lose it, right?
Right.
Says the date of injury, what our current recommendations are, so that they can literally email that straight off to the professors and advisors to have that first conversation. And then an intake visit is what happens at disability services. They would just go on. I think they can schedule that online or call. And then sometimes they can get some temporary medical accommodation. And then our speech and language and hearing science department, if they are doing some testing on them cognitively, they will help write letter on the behalf of the student and work with disability services kind of directly to get that done.
Yeah, and I think that's important. You know, there's lots of steps to get more help, right? And so we start with the basics, and then we watch how they do. And again, thankfully, majority of people do great. But for the folks that don't, there's lots of things to do in terms of more formal cognitive rehab, more formal recommendations for the classroom, talking about what does a medical withdrawal look like. There's lots of good information out there that we can help them with. Kathy, do you have a question?
And it looks like we have a question.
Sorry, you covered what I was going to ask. Thank you.
Cool. Chris, great question. So this is, he said it's okay if people go out and get a coffee after concussion. Are there any concerns with coffee, nicotine, or any other supplement prescription drugs after concussion? Great question. So a couple of different things there. So one is we're worried about caffeine withdrawal causing symptoms, right? So if you're a big coffee drinker and then you suddenly don't drink coffee for a couple of days, you're going to have a horrible headache, whether you have a concussion or not. So for caffeine, at least, I tell people, you know, you probably don't need as much as you normally had, and we want to get back to your sleep schedule as normal as possible, as quickly as possible, but don't go from 3 coffees a day to none, or, you know, 6 Cokes a day to none. We don't want to have any significant change there. I would probably say the same for nicotine, honestly. I mean, we wish none of our folks smoked, but again, we don't want to have significant withdrawal symptoms. If you think about withdrawal, it probably feels a lot like a lot of those symptoms we talked about in concussion, right? So you're irritable, you're fatigued. So again, we're trying to maintain a baseline. Now, important to know, and important for alcohol, important for other drugs and prescription drugs and for nicotine, is that the injured brain has an injured blood-brain barrier, right? And that's what that kind of protects the brain from the chemicals in our bloodstream. And so when it's injured, more of that stuff enters the brain, right? More nicotine enters, more alcohol enters, more THC enters, right? So making sure patients are aware of that, you know, hey, your 2 cigarettes in the morning or your 3 Juul puffs in the morning might cause you to have more of a reaction, or more of a kind of, you might get more out of that than you normally would. So start really, really slow. So again, alcohol and other drugs, we go with abstinence. That's by far the easiest. We know alcohol is a toxin to the brain. The data behind THC in the brain in terms of concussed brain is very mixed at best. And so we stick with, abstinence. So we recommend people take their prescriptions. So if you're prescribed a medication, you can take your prescriptions. Alcohol and, street drugs, we would say abstain. And then for caffeine and nicotine, maybe start with a much smaller amount and see how you do. But I think suddenly changing your intake of those substances in particular might cause their own set of symptoms that might cloud the picture.
Yeah, and there's no contraindication from any of our governing body that says any medication prescription-wise is contraindicated.
Right.
And especially we get a lot of this about, my SSRI medication, my ADHD medication. We don't want you to stop that. Now, if you don't have to take your ADHD medication the first day or two because you're sleeping a lot, that's okay.
Right.
But we certainly want you to take it because you're going to probably struggle to have as much focus in the classroom because of your concussion. So we don't want you to stop that medication.
Well, I want to just pause and recognize that we're at time. Let's first, before we sign off, just give a really sign of gratitude to our awesome physicians helping to care for our students with concussion and mild traumatic brain injury. We will be posting this on the Be Well website. And I also encourage everybody to check out Be Well on a monthly basis. We have new wellness resources for all of our community coming up, as well as our subsequent Let's See You Well presentations. So a huge bow of gratitude from us coming your way. And thank you so much for everyone in attendance today. We hope to see you next month at our next Let's See You Well. Thanks so much.
Thank you. Thanks for having us.
Yeah,
It was nice talking to you.
Everybody showing up. Great questions today.
Happy New Year, y'all.
Take care.